Hey guys, Dr. Sil here, junior doctor from Sydney, Australia. I thought I'd just have a little bit of a rant about depression. I'm working in mental health at the moment. I'm doing a forensic psychiatry placement. It's the highest level security mental health facility in Australia, and it's really where you see the most difficult to manage serious mental health problems. You know, mental health is just fascinating, the brain is fascinating, and it's a really, really big problem in society is the burden of mental illness. Anyway, I've learned a lot about depression during this time, and I thought I'd share some things. And I think the first thing to talk about when you talk about depression is the seriousness of it. And also why does depression exist? It's the most evolutionarily illogical thing. But anyway, we'll get to that. So the seriousness around depression, it is the fourth, global leading cause of disability in the world. It is absolutely massive as a problem, causing billions a year to the economy, because when people are depressed, obviously they have no motivation and everything is really hard to do. Even having a shower can be like a monumental task. So massive problem. And even if you have cancer, you have an ability to appreciate life. You go, fuck, I have cancer, but now I'm reconnecting with my friends. A lot of diseases make you kind of grateful for life, but depression sucks the ability to enjoy things, including seeing your friends, including everything else. So it sucks the fundamental nature of what it is to be human, which is to have motivation to do things. So it's just this kind of insidious, dark thing that removes the soul of what it is to be a human, and it's quite an evil disease. A guy called Robert Sapolsky in Stanford University summarizes it really well in a one-liner. He goes, depression is a physiological state that has genetic childhood something along the lines of depression is a physiological state that has a genetic predisposition and influenced by early childhood events that results in you not being able to appreciate sunsets, which is a really fundamental thing to say. So you have this genetic risk where you have certain genes that might not be expressed, but you have the genes, because by the way, a lot of your genes aren't being expressed at any one time. It's called epigenetics, and whatever genes are expressed is influenced by the environment. So you have these genes that are kind of switched off, and then you have these environmental stresses. We don't exactly know what they are, but there's a lot of things that we know influence the risk of depression, like adverse childhood experiences, so sexual assault and abuse and things like that. And then, that triggers this set of genes to we don't exactly know what happens, but we know that neurotransmitters play a significant role. And so it changes the expression of neurotransmitters and the amount that are in the synapses. And then the pathways in the brain fundamentally and structurally and physiologically change, right? The reward pathway is blunted, and there are biological differences in the brain of someone with depression. We kind of worked this all out through the treatments that affect depression. So, the first line of treatments were treatments that affected norepinephrine, so there was monoamine oxidase inhibitors, and then there was tricyclic antidepressants as well, and that also affected the amounts of epinephrine. But there are a lot of side effects with those medications. And so then the next bunch of medications we discovered had an influence on depression with dopamine acting medications. We noticed people with Parkinson's disease who have low levels of dopamine in certain pathways had higher risk of getting depression, and if you gave people that medicines that increased the amount of dopamine in the brain, then their depression would be relieved. So we knew dopamine had a role, and then the most recent class of medications, which has variable effectiveness with different people, is SSRIs, selective serotonin reuptake inhibitors. So we know that serotonin has a role in the pathophysiology of depression. But the brain is just this impossible organ to get into and understand. So we can't really understand why there is less serotonin in the brain. We have found some people with depression have genetic problems in some enzymes that make sense. So there is a gene that affects the monoamine oxidase enzyme, and people with problems with that gene will have an increased risk of depression. And that physiologically kind of makes sense with our understanding of the role of norepinephrine or noradrenaline in depression, because that's an enzyme that's really important in the metabolism of that neurotransmitter. So we're kind of working it out. There's still a lot of work to do. In understanding why people get depression. Someone who is depressed has these awful set of symptoms. The symptoms, they include problems with sleep. So often you have really early waking, so you're waking up at 4 or 5 a.m., but then not being able to leave the bed, like just feeling just stuck there. There's often symptoms of like guilt, feeling like you are worthless and causing like harm on others, and that leads to suicidality, so wanting to end your life. It's really important, if you know someone who you think might have depression, to talk to them, and when you talk to them, also ask them about suicide. Very common misconception that asking about suicide might increase the risk of suicide. Not true. You know, if someone wants to suicide, they've been thinking about it, and you asking about it is much more likely to be good than bad, because it'll give them an outlet to talk about these things that they might feel like they otherwise can't talk about with anyone else. And full disclaimer, I have asked many of my friends about suicide, and sometimes it's quite shocking. Like if they're going through a hard time, they go, "No, what? I'm like, come on, dude, what? I'm not like suicidal." But I don't care if that shocks them or if it like, feels inappropriate. It's way better to ask about suicide than to not ask about suicide. If you want a free one-liner on how to ask about suicide, because it can be a hard thing to bring up, you can just say something like, look, it looks like you've been going through a really hard time, and I know that people who are struggling can often think about hurting themselves or even ending their lives. Have you been having any of these kind of thoughts? That's a pretty confrontational way of bringing it up, I think. Other symptoms to consider can be more subtle, so problems with concentration, and that can present itself with like bad work, or like bad grades, and also irritability. So if someone's just like being rude and grumpy, a lot of the time it's because they're suffering, right? Especially if it's out of the blue. So yes, it's tempting to be like, oh, that guy's a prick, like, oh, no one likes him, he's a grump, whatever. But he's probably got like a type of depression. And that's another thing we need to talk about. There's lots of different types of depression. There's like the full-blown melancholic depression, which, you're stuck in bed, you haven't showered for days, you haven't eaten for days, your sleep's all over the place. It's like very clear-cut melancholia. And then there's like milder but longer-term depression, things like persistent depressive disorder, where you've just like not really been enjoying life for years. And there's like seasonal affective disorder, which is thought to be related to the amount of light exposure you have, so it's worse the further away from the equator you are. And there are other types of mood disorders, adjustment disorders, if someone's passed away, and also that can lead to like, you can also get depression with psychotic features, where you're so depressed that your brain starts developing psychotic symptoms, things like delusions and hallucinations even. So you might hear voices telling you that you're worthless, and you might believe that part of your body is rotting and things like that. Now, I guess the key takeaway from this video, if there's one thing for people to like take away from this rant, is that just get to a healthcare professional. Just get to the door. Yes, it costs money in some places. In Australia, there's public healthcare, which is really good. Yes, it can be hard to leave the place, and if you're worried about a friend, like, try and help them if you can. It's also important, when I say you've got a friend with depression, try and help them if you can. It's also important to recognize that you need to have boundaries in relationships, and you also need to recognize you can't change everything. So if someone really doesn't want help, but they're not like a risk of harm to themselves or others, then they have the right to be depressed. It's not illegal to be depressed. It's important for you to like respect their rights. But that's a really tricky situation. So we've talked a bit about depression, the importance, some of the kind of pathophysiology, what causes it, and how that relates to some medications. We talked a bit about some of the symptoms. I guess we should also talk about other forms of treatment. So we've got to approach it from the biopsychosocial approach. Now, there are side effects with SSRIs, and a lot of people experience sexual dysfunction with them, and that's a really serious side effect. And so there are alternatives and second-line treatments to use if you are experiencing these kind of side effects. Bupropion is often used if you have sexual side effects. You know what? Talk to your doctor. I'm not going to go through them because I don't want this to influence whether you see a doctor or not. So you can talk to them about the different side effects, but they can be significant. Maybe 80 to 90% of people won't have any side effects, and there's that 20% that do. So those have to get the second line treatments. Another big question around depression though is that if it is just about neurotransmitters, why isn't there a 100% response rate when people are on these medications? And why does it take so long to respond? Like, if you have the answers to these questions, put it in the comments below, because I haven't found the answers. There was the big STAR-D trial, which was done in the 2000s, which was the biggest trial ever to look at the efficacy of antidepressants. And that showed that 30% of people will respond to first-line therapy, okay? So second-line therapy is another 30%. So, you know, that's most people can respond to the first 2 medications. So at least try. Now, I'm a doctor, I'm talking about medications. Yes, I get it. You know, it's pretty biological. You need to think about psychosocial interventions as well. So cognitive behavioral therapy is like the most rigorously studied and most effective shorter term psychotherapy that you can do with a psychologist, and you can do it online. Like there are apps now for cognitive behavioral therapy. It just involves like challenging thoughts. So if you or someone you know has depression, like you can just use an online app to do your CBT, and that's like really important. Often I think of the medications as a good pair of hiking boots and the psychotherapy as the mountain. It's really hard to walk up a mountain barefoot, so it's good to have a good pair of hiking boots on to kind of like help you on that work that you have to do in the psychotherapy, and then you have to walk the mountain. And that's biopsycho, but you have to think about social treatments as well to depression. So yeah, activities with other people, talking with your friends, having good healthy relationships. These are all really important. Getting a dog, you know, like it's small, but it has a really significant impact on like the less melancholic type of depressions. Depression is a biological disease. So if you have a melancholic depression where you just cannot feel joy, it doesn't matter what you do unless you're treating that medically, because you need to treat the lack of serotonin in the brain essentially, but then get a dog. I'm very pro dogs, I hope you know that. I guess the final thing to talk about with depression, which I won't go into too much depth, is that comorbidity is the rule, not the exception. So if people are depressed, often they'll try and self-medicate, and that often takes the form of alcohol, which yes is a depressant, but also it makes you lose the kind of frontal lobe overthinking part of your brain, and makes you disinhibited, and that can feel good. So a lot of people do alcohol, but a lot of people do other drugs that make them feel good. So you have to really monitor comorbidities such as anxiety, drug use disorders, and also like a lot of depression is bipolar. So people with bipolar disorder will be mostly depressed and just have episodes of mania. And you know, you don't need to know this, but a doctor should not treat a bipolar depression with an SSRI, especially if there's no mood stabilizer as well. The treatment with medicines becomes complicated with bipolar. And so the key thing there is having a really good history. And so you need a good doctor, and so you need to find yourself a doctor. You know, I'm very pro doctors because I'm a doctor. All right, that's my rant done. I hope you enjoyed it. Have an absolutely wonderful day. Put any questions in the comments. Let's talk more about mental health. I'm sorry I haven't done many mental health videos lately, but this is very helpful for me to just have these rants. And if you guys find it interesting, then that's fantastic. And if you don't, I'll probably still continue to do them. All right, I'll see you guys in the next episode. Bye for now.